Good morning again. I'm going to speak to you about a clinical topic that I've been involved in, including some of the members who are here with you today, Elena Vasilyeva and Filippo Crea, among others, have been involved with us through the European Society of Cardiology, the American Heart Association, the American College of Cardiology, and the World Heart Federation. All of the major heart organizations in the world have gradually joined this. It was an effort that began between the American College of Cardiology and the European Society of Cardiology in the late 1990s with my good friend Professor Christian Thuesen from Aarhus, Denmark, and myself. And we were able to get a task force going that, as you will see, has published a number of documents in an attempt to have the diagnosis of myocardial infarction be the same in Moscow as it is in Tokyo, as it is in Tucson, Arizona. We noticed that many times there would be articles published that contradicted each other with respect to therapy, and we discovered very quickly it was because people were defining their patients differently, so they were trying to compare, as we say in English, apples to oranges. You want to compare oranges to oranges and apples to apples. So that's what started this whole process. Let me take you through it then. I hope everybody understands this. This is the result of the wonderful internet, where you enter the words in English and say, translate it into Russian for me. And so here we have it. In any case, these are my potential conflicts, but none of them have anything to do with the topic of the universal definition. So already in the late 1960s, early 1970s, the World Health Organization was trying to come up with a universal definition for myocardial infarction so they could compare the statistics, just like you just heard so elegantly presented, between Russia and the United States and Latin America and Asia and so forth. So their definition, defined at that time, was very much based upon the clinical story and the electrocardiogram. Well, of course, later we added serum markers, and today we call these, of course, biomarkers. And the advent of the troponin assay, which is highly sensitive and specific, has enabled us to very accurately determine individuals who are having some form of myocardial injury, of which some of those injuries are due to ischemia and are therefore myocardial infarcts. So you can see the WHO definitions were entered back in the 1960s and 70s. These are predominantly epidemiologic definitions based upon a meticulous analysis of the electrocardiogram and the history. And you can see our first report came out in 2000, a revision in 2007, another revision in 2012, and the fourth revision will be expected in 2018. We have finished the document in our first draft, and it's going out for review. Now, I'm going to show you information that's in that document. So, Filippo and Elena, you must promise not to tell Christian Thuesen that I'm sharing this information with you before the publication. And, of course, there may be some revisions because, of course, we will receive critiques and we'll be revising the document. But based on past experience, I think this is at least 90% accurate. So let us... So just to show you, these are the three documents that have been published so far. They're published simultaneously in the European Heart Journal from the European Society of Cardiology, in circulation from the American Heart Association, and in the Journal of the American College of Cardiology from the American College of Cardiology, and Nature Cardiology from the World Heart Federation. And 2018 will be the next one. Next slide, please. So let's talk about the definition itself. You can see here, we're attempting to show clinically something that reflects the pathological definition. And the pathological definition is exactly this. It is acute myocardial infarction is defined when there is a myocardial cell death or a myocardial injury that results in myocardial cell death, and it's due to ischemia. Now, what you're going to realize is, of course, myocardial cell death can occur from a lot of different things. For example, you could have myocarditis, an inflammatory infection of the heart. You can have autoimmune attacks on the heart and so forth. These are not myocardial infarcts. These are myocardial injuries, myocardial necrosis, cell death due to something else. When it's due to ischemia, lack of blood flow, that defines myocardial infarction. And so this was the original definition, and it has changed very little through the various documents. You can see it's based, first of all, on demonstration of myocardial cell death because of a rise and a fall, or rather a fall if you come a little later, in the blood troponin value. Most of you know, I'm sure, that troponin is one of the intrinsic molecules involved in the contractile machinery of the heart. And when we see it in the bloodstream, the release of this large molecule means that the myocardial cell has lost its membrane integrity and has died. And then, in order to diagnose a myocardial infarct, you have to, first of all, demonstrate that there's been cell death with the troponin, but then you need at least one of the clinical characteristics that say that there's ischemia. Either the patient has a very good story consistent with ischemia, or they have electrocardiographic changes, or they're of either ST segment depression or development of Q waves, or through imaging we see loss of wall motion. In other words, the heart has stopped contracting because of the ischemic injury. And occasionally it is, of course, found first at autopsy. And of course, we now know that some individuals can suffer a myocardial infarct without coronary disease, and these people also have had a myocardial infarct. It's just not the one that's due to atherosclerosis. Starting with the second document in 2007, we began to subdivide the types of myocardial infarct. Type 1, that's the one that people see most. That's the one that comes to the emergency room, the ST elevation MI. The patient comes in clutching their chest and telling you there's an elephant sitting on their chest. The EKG almost always shows you ST segment elevation or depression. And it's usually, almost always, but not always, due to an ulceration or rupture of an atherosclerotic plaque with the development of platelet aggregation and blood clot, which blocks the artery and results in ischemia. So cell death secondary to ischemia because blood flow has been interrupted. And in fact, this is very similar to what we will see in 2018 in the next revised document. So this has not changed. What changed, by the way, this is just a little cartoon to show you. Here you can see just what I just said, that there are some examples of what happens within the artery. There is an area of rupture of a plaque, a blood clot forms. It's either subacute or complete, or you can have an atherosclerotic dissection also with a blood clot forming. So this is a type 1 MI. This is the kind of MI that we deal with every day from the emergency room going to the catheterization laboratory, and that has been so successfully handled by Dr. Spector's STEMI group here in Moscow. Let's go forward. So a second type of myocardial infarct was defined starting in 2012 and has created some confusion. The type 2 myocardial infarction is not due to a ruptured or ulcerated plaque with a blood clot, but it is due to a change in either oxygen consumption of the heart or oxygen demand. In other words, there's an imbalance between supply and demand. There's not a plaque rupture. The artery is open, but the heart is being stressed either by too little oxygen delivery from low blood flow or low oxygen carrying capacity, for example, severe anemia or hypotension from hemorrhage, or it is being overly worked because of, let's say, rapid tachycardia, atrial fibrillation with a heart rate of 180. Even a young child, if they have a heart rate of 180 for a prolonged period of time, there are going to be subendocardial myocardial cells that will die from ischemia because of the overwork. And I will show you this in a little more detail. Again, here's the diagram that says, what are we dealing with? We're dealing with a supply-demand imbalance. Either the supply has gone down because of the example I gave before, anemia with low oxygen carrying capacity or hemorrhage with low blood pressure, or because of excessive demand, marked hypertension or marked tachycardia. In other words, we're either seeing a marked increase in afterload or preload of the left ventricle. And here we see some examples of the type 2. You can see could be also due to coronary endothelial dysfunction, can be coronary emboli, tachyarrhythmias, respiratory failure, a whole variety of things. And I'll show you a list again. Those of you who want to look at the document, you'll see the very complete list. And it's a huge number of potential medical situations that result in either decreased blood flow to the myocardium or increased myocardial work. And here, here we see a little diagram that shows you the kinds of things that can lead to a type 2 myocardial infarction. You can have endothelial dysfunction with spasm or endothelial dysfunction. You can have fixed atherosclerotic disease with a sudden increase in demand or decrease in supply. You can even have so-called normal or patent coronary arteries, even with very severe change in demand. Or you can have a non-atherosclerotic coronary dissection that results in this so-called type 2. What's important about that is the treatment is not a rush to the cath lab in order to open the artery, because the arteries are very often already open. And it's a question of correcting the supply-demand imbalance. So that in a sense, you're overworking your horse or you're underfeeding your horse, but opening up the horse's artery is not going to help. There are 3 other types. I'm not going to talk about them today because of the time limits. A type 3 MI is where, again, just like the original WHO definition, troponin is not available either because the hospital doesn't have it or because the patient dies before a troponin can be obtained. It's, in other words, a clinical diagnosis based on the EKG in the story. Type 4 is a myocardial infarction that occurs as a complication of angioplasty. That is one of our interventional procedures. And type 5 is a myocardial infarct that occurs because of a complication in the surgery suite. We're really just going to talk about type 1 and type 2 today because that's the overwhelming number of patients that we see as clinical cardiologists in the clinic. So how do you differentiate type 1 from type 2? Well, remember, type 1 is a plaque rupture with a clot. Type 2 is either a vasospasm or abnormality in endothelial function, or it is a sudden change in demand or supply because of another process, and that can occur in the absence of coronary disease. And I can tell you a week doesn't go by that I don't get an email or a telephone call asking, do you think this was a type 1 or a type 2? Should we be taking all these people to the catheterization laboratory? And of course, the answer is it depends on the circumstances, it depends on many factors, the patient's comorbidity, the kind of presentation, and so forth. Again, clinical judgment will always be a characteristic here. But here are some qualities that can help you make the decision. Type 1 MI, that is with the blood clot forming on an ulcerated plaque, is usually spontaneous in onset, often in the early morning hours. The underlying process, as I've mentioned a number of times, has to do with rupture or atherosclerosis, fissuring of the plaque. Almost all the ST elevation MIs are in this category, and the patients do not usually present with a serious medical illness such as pneumonia, gastrointestinal bleeding, sepsis, and so forth. However, the type 2 MI, the onset of the MI is often in the setting of a serious illness. For example, hypotension from sepsis or from hemorrhage, respiratory failure with marked hypoxemia, rapid tachycardia, atrial fib with a rapid heart rate. Again, you can see the supply-demand relationships have been upset, but the patient doesn't present early in the morning with usual chest discomfort. And the mechanism is not a thrombosed artery. The mechanism is a supply-demand imbalance of myocardial oxygen supply. So distinguishing type 1 from type 2 is a clinical process. You need to think about what is the underlying pathophysiologic mechanism based on your interpretation of the patient's history, the electrocardiogram, and possibly also some non-invasive studies. So in the end, it's the cardiologist or the cardiac nurse specialist that has to think about these things in deciding, is this a type 1 MI? We need to go to the cath lab to open the artery. Or is this a type 2 MI? We need to work on correcting the supply-demand imbalance. There's a third category, and this turns out to be very common. This is a myocardial injury where there's no ischemia involved. And I mentioned it right at the beginning, myocarditis, cardiac trauma. Someone's in a motorcycle accident. There's chest trauma. The myocardium is bruised and injured. Troponin rises. You can actually see abnormal wall motion, but the whole thing heals, and there's no ischemia involved. Therefore, this is not a myocardial infarct. So it's diagnosed when there isn't a cardiac injury, troponin goes up, but in fact, there's no evidence of ischemia. Sometimes troponin goes up and stays continuously elevated, which tells you that there's ongoing low levels of myocardial damage going on. We see it in some patients with end-stage heart failure. We see it in a lot of dialysis patients. It's not good. It augurs a bad prognosis, but again, it doesn't mean you need to go to the cath lab to open up a blocked coronary artery. So the criteria for a myocardial injury is any time when we see an elevation in troponin, either persistently elevated or rising and falling. If it rises and falls, it's acute. If it stays elevated, it's chronic. And then we have to say, what is the underlying mechanism? If it's ischemia, it's a myocardial infarct. If it isn't, it's a myocardial injury secondary to another process. And so the myocardial injury due to an acute event, for example, a trauma to the heart, myocarditis, chemotherapy, anything that can injure the heart where ischemia is not involved, that is called a myocardial injury. When there's a plaque rupture and the artery clots, that's a myocardial infarct, usually a type 1. So here we have a myocardial injury related to acute myocardial ischemia as a result of myocardial supply-demand imbalance. That's a type 2 MI. And here are examples we've talked about before: tachycardia, hypotension, spasm, microvascular endothelial dysfunction, coronary embolism, and so forth. Here's another example of type 2. This is, of course, increased myocardial oxygen demand, so increased heart rate, tachycardia, increased systolic blood pressure, marked increase in contractility, for example, great fear with release of adrenaline, or reduced oxygen carrying capacity from severe anemia or hypoxemia in respiratory failure. So these are the supply-demand imbalance infarcts. They don't mean that there's a blocked artery, and they don't mean that you need usually a cardiac catheterization. If we go forward, you can see that a myocardial injury which is unrelated to ischemia and therefore not a myocardial infarct, but just a myocardial injury, and you can see lots of things here. There's heart failure, myocarditis, cardiomyopathy, Takotsubo syndrome, right down the line. There's a whole lot of things that can injure the heart. We frequently get consulted to come see patients in the medical intensive care unit who have an elevated troponin in the setting of a severe medical illness, let's say sepsis with hypotension. And these are often people who have no history or of risk factors or don't have coronary disease when evaluated. The issue is there's been a direct injury to the heart, probably from elevated catecholamine or cytokine injury. It turns out that from experimental studies, TNF can be an injurious factor to myocardial cells and can be demonstrated in experimental animals and even in culture of myocardial cells. So these are not myocardial infarcts. They're due to systemic conditions, as I've said, sepsis here, a whole bunch, pulmonary embolism, a whole bunch of things. And this is where the really good clinician comes to the foreground. When you see there's an elevated troponin and you work through to find out, could this be due to ischemia? If so, we need to take a look at the coronary arteries and think about opening up the coronary arteries. If it's not due to ischemia, we need to take care of the underlying internal medicine condition. And just a little diagram to show you that what happens with the acute event, like a myocardial infarct or even trauma, there's a rise in troponin and then a fall, and then you see the elevated chronic value that we see in some heart failure patients and some dialysis patients, again telling you that there's low-grade ongoing myocardial injury, not due to ischemia, but due to the underlying illness. If we could have the next slide. How do you recognize the type 2 in the clinical setting? Well, here's two examples. Here's a 14-year-old boy, unlikely to have coronary disease. He has supraventricular tachycardia for 5 hours with a heart rate of 180 beats per minute, troponin elevation. This is probably a type 2 MI, although you then have to explain to him and the family that this is not something that carries a bad prognosis as long as we control his supraventricular tachycardia. Here's a 75-year-old man who has known heart disease, coronary heart disease. He has marked anemia following an upper GI hemorrhage. Is this a type 2? This may well be both. This may be a supply-demand infarct, but of course, because we know he has underlying coronary disease, maybe there's also a coronary event here as well. These things are not mutually exclusive. They can occur together, unfortunately. And then again, you have to work through the clinical process of how much aggressive treatment you're going to consider. Just to show you that type 2 MI is bad news. And of course you know that, because if it's occurring in the medical intensive care unit in the setting of severe disease like sepsis and respiratory failure, there's going to be a high myocardial infarct rate. So here's an article from Denmark with my friend Christian Thuesen, and also from Odense, Denmark, Hans Christian Andersen's hometown, published in the journal that I edit. And you can see that in blue is the mortality rate over 3 years for type 1 MI. That's the one where we open up the artery. And look at the mortality rate, or the survival rate rather, much lower survival rate for type 2, because these people are very sick with a different illness. And if you compare type 2 to the myocardial injury, in fact, they're both terrible. What it tells you is when the heart gets injured by some process, it's not good. And whatever that process is, it usually expresses severe underlying disease. So in fact, the joke here is it's much better to have a heart attack than to have a myocardial injury secondary to respiratory failure or hemorrhage and so forth, because your underlying illness is in the end going to be what's going to kill you, and the heart is just a marker. It's just like acute kidney failure in these settings. It's saying, guess what, folks, I've lost homeostasis, the body is in deep trouble, and there's a high likelihood of dying, but you're not going to die from the heart. You're going to die from your underlying disease. And this little diagram just shows you that you can have a type 1 MI, you can have a type 2 MI, or you can have a myocardial injury in situations like renal dysfunction, angioplasty, acute heart failure, pulmonary embolism, arrhythmias, and so forth. So again, the clinician has to step to the foreground, look over the conditions, and decide what's going on underneath here. Is this an acute coronary artery event that needs a trip to the cath lab, or is this secondary to the illness, and we just need to focus really all of our attention on getting the patient better? And this little diagram will be, again, don't tell anybody you're seeing it, very likely the diagram that you'll see in the 2018 publication, and it just takes you down the two sides. What happens when you see troponin without acute myocardial ischemia takes you all the way down through the various causes, such as heart failure or supply-demand imbalance. And on the left side in pink, acute myocardial ischemia that takes you to myocardial infarct, where you do need a cath lab event. So again, what makes me happy about things like this is it means the clinician makes a difference. Otherwise, we could just let a computer make all the decisions and we can all go on vacation, to the beach. But our patients really need us. They need us to understand the underlying mechanism and then to attack the underlying mechanism. If it's coronary artery disease, we need to go after it with our medicines and our cath lab, and if it's not, if it's a comorbid illness, we need to go after that illness and help our colleagues get the patient better. So, next slide, please. Well, okay, let me then just summarize. Here we go. So here are the summary of the definitions. Myocardial ischemia, some evidence clinically, plus EKG changes. That's a myocardial injury that's manifested by rising and falling value. Ischemia, that's an acute MI. Myocardial ischemia not present, rising and falling troponin is a myocardial injury. And if the troponin levels are elevated and stable, that's a chronic ongoing injury. And here's the good news, that starting this October, next month, the ICD-10 is going to have a code for type 2 MI. And we're working with them also to have a code in the very near future for myocardial injury, not ischemia. That's being discussed at this very moment. Thank you very much.